Welcome to the Deep Dive. Today we are cracking open a single source document to really unpack a chemical you have almost certainly felt. Even if you didn't know its name at the time, adrenaline.
Exactly. We're doing a deep dive based on a podcast and monograph from paramedicine.com featuring Mark Kolbeck. And it really positions adrenaline as, well, maybe the most fundamental drug in emergency medicine.
Right. And our mission today is to go way beyond just, the casual idea of an adrenaline rush. We want to understand this molecule from the ground up. It's pretty wild history. What it actually does at a cellular level, why paramedics rely on it so heavily, and, what insights it offers for anyone just fascinated by how our bodies work under pressure.
Yeah, the source doesn't mess around. It says right off the bat that if a paramedic could only carry one drug, just one, adrenaline might be it.
That's a huge claim.
It is. It's bold. And the source really lays out the case for why it thinks that's true.
So if one drug out of everything a paramedic carries could be singled out like that, well, that tells you this is serious stuff. By the end of this deep dive, you're definitely going to have a whole new perspective on its power, and maybe its paradoxes too.
So where does the story start? Well, it really starts with our biology, doesn't it? That ancient primal fight-or-flight response.
Yeah, the source reminds us, long before science figured it out, our ancestors felt that surge, the racing heart, the tunnel vision, when danger showed up.
That raw physical feeling, that was the body's own system kicking in, driven by this chemical.
It's amazing. And scientists back in the late 1800s started to suspect it came from the adrenal glands.
Specifically the adrenal medulla, yeah, the inner part. And, oh boy, the source shares this absolutely wild story, maybe a bit grim, about the early experiments.
Oh, you mean George Oliver and his son in 1893?
That's the one.
Getting his kid to swallow sheep adrenal gland extract just to see what happened? I mean, wow. That wouldn't get past ethics today, would it?
Not a chance, no. But Oliver, he noticed a key thing. It tightened up blood vessels, vasoconstriction. And that discovery basically lit the fuse for the race to isolate the active compound.
But it wasn't straightforward. There were some dead ends, like Otto von Firth.
Right, he misidentified it, called his thing superanin. Then, 1897, you had John Abel, an American scientist. He isolated something he was sure was the pure stuff.
And he called it epinephrine. Okay, got to remember that name.
Definitely. Because the real breakthrough, the source details, came in 1901. Yokichi Takamine.
He sounds like quite a character.
Oh, yeah. Prolific chemist from Japan, son of a samurai doctor, encouraged to study Western medicine. Takamine managed to isolate the pure, stable form of the hormone.
And he used the name adrenaline, which was sort of already floating around, especially in Britain, right?
Yeah.
For the substance from the adrenal gland.
Exactly. The source even mentions he tweaked the spelling slightly to adrenaline with an I, initially, as a kind of legal move.
Ah, because he did something huge next.
He did. Revolutionary and super controversial at the time. He patented it, this naturally occurring hormone.
Patented something the body makes.
Yeah, he had to fight this massive lawsuit. People argued, you can't patent nature, but he won. And that victory, well, it's at a massive legal precedent. Huge implications for medical science, the drug industry, stuff we still deal with today. The whole idea of patenting isolated biological compounds.
That alone is fascinating. A major implication changing the game for drug development. But what about Abel, the guy who called it epinephrine? He wasn't too happy, I gather.
Not at all, no. The source says Abel felt, scooped, unfairly beaten. He apparently went to his grave believing his earlier work was the correct isolation. And, combined with some pretty unfortunate xenophobia against Takamine in the U.S. back then. It led to what the source calls the name war.
Which is why, even now, over 120 years later, we're still using two different names. Epinephrine, mostly in the U.S., adrenaline, pretty much everywhere else.
For the exact same chemical, C9H13NO3. It's kind of nuts, isn't it? But it's a direct result of that scientific rivalry in history.
It is absurd. And the source points out both names actually mean the same thing anyway.
Yep. Adrenaline from Latin, epinephrine from Greek, both basically mean above the kidney.
Okay, but just to make things even more interesting, scientists later found another compound really similar. C8H11NO3.
Noradrenaline, or norepinephrine.
Yeah.
Took them, another 30 years to realize it wasn't just adrenaline that wasn't quite pure.
So it's a different molecule.
It is. And noradrenaline is actually a precursor. The body makes adrenaline from noradrenaline. The nor-R part, apparently, originally referred to a structural thing, like a normal version in a chemical series.
Okay, so they're like chemical cousins, Very similar, but the source makes a big point. They are not interchangeable clinically.
Definitely not. Adrenaline is the common emergency drug paramedics carry day to day, whereas noradrenaline, or norepinephrine, that's described as more of a high-level critical care drug, usually given by IV pump, continuous infusion, mainly used for its really intense vasoconstriction to keep blood pressure up in seriously ill patients. Different drug, different use, different level of training needed.
So once Takamine got that pure adrenaline out there, its medical uses just took off.
Absolutely exploded. The source points out people like Solomon Solis Cohen were trying it on asthmatics almost right away around 1900 with really dramatic results.
Wow.
And by 1910, you had articles in top journals like The Lancet reporting marvelous results from tiny doses, like 600 micrograms.
600 micrograms. It sounds tiny, but obviously potent.
Yeah.
And you mentioned vasoconstriction earlier. That must have been huge for surgery.
Revolutionary. Slap some adrenaline on, stop the bleeding in the area you're working on. Huge deal. And using it for severe allergic reactions, anaphylaxis. That started really early, too.
And it even led to a practical invention.
Yeah, the glass ampoule. Because this stuff was powerful, but unstable as just an extract, putting the pure liquid form in a sealed glass ampoule made it safe, stable, usable. Became a doctor's staple.
The source does mention, though, like a lot of wonder drugs, it kind of went through a phase of being seen as a fad cure.
Yeah, that happens, doesn't it? A big discovery, then maybe overenthusiasm trying it for everything. That's maybe a weakness in how medicine sometimes adopts things. But the real life-saving uses stuck. And now it's so fundamental that, regular people carry it in auto-injectors, EpiPens, Anapens. That's a massive practical application right there.
Okay, let's switch gears a bit. We've got the history, the impact. How does adrenaline actually work? What's it doing inside the body?
Right. The source breaks it down really nicely into 4 main effects, and it all comes down to how adrenaline interacts with specific receptors on our cells.
Receptors, like docking stations on the cell.
Pretty much, like locks on the cell surface. Adrenaline is the key. It fits the lock, turns it, and makes something happen inside the cell. We call it an agonist. It activates the receptor.
Okay, got it. Agonist activates. So where are these receptors? Effect number 1?
Effect 1 involves alpha-1 receptors. These are mainly found in the smooth muscle that lines your blood vessels.
And when adrenaline hits these alpha-1 receptors,
it causes vasoconstriction. The muscles squeeze, the blood vessel tightens up.
Okay. So that explains the stopping bleeding and surgery thing and why they use it in dentistry to keep the local anesthetic, like lidocaine, from just washing away.
Exactly. Which brings us to that really important warning the source gives, that mnemonic.
Oh, yeah. Never use lidocaine with adrenaline on nose, toes, fingers, or hose.
Right. Hose, meaning the penis, because these areas already have a sort of limited blood supply. If you add adrenaline's powerful local vasoconstriction,
you could cut off the blood flow completely, kill the tissue.
Precisely. A really critical, practical point that comes directly from understanding this specific receptor effect. You need to know where you can and can't use it.
Paramedics leverage this alpha-1 effect in cardiac arrest too, right?
They do. But this is where the source brings in a really important nuance and a major ongoing debate in medicine. When paramedics give adrenaline IV during CPR, usually it's 1 milligram every 3 to 5 minutes.
Yeah.
The main goal isn't actually to restart the heart directly with that dose. It's mostly about the alpha-1 effect, causing vasoconstriction everywhere else but the core.
So squeezing the vessels in the arms, legs, gut to push the blood towards the heart and brain during compression.
Exactly. You're shunting the limited blood flow to where it matters most, making the CPR itself more effective at perfusing those vital organs. But, and this is a huge point of critical evaluation the source stresses, the Paramedic 2 trial, big study published 2018, it really cast doubt, as the source puts it, on whether this standard practice is ultimately beneficial.
Oh, right. That's the one that showed it helped get people's hearts restarted, maybe get them to the hospital.
It didn't necessarily improve survival with good brain function.
Yeah. So more initial survivors, but maybe not better long-term outcomes.
That was the troubling finding. It raised really profound questions about the net benefit. So this is a major weakness, or at least a serious limitation being questioned, about using adrenaline in this specific, very common scenario, a real clash between established practice and newer, large-scale evidence. It's a hot topic.
Wow. Okay. So that's alpha-1 on blood vessels, vasoconstriction used for bleeding, CPR perfusion, but with a big question mark over the cardiac arrest benefit now. What's effect number 2?
Effect 2 is via beta-1 receptors, and these are found pretty much only in the heart.
Okay. Easy mnemonic, one heart, beta-1.
You got it. And adrenaline is a beta-1 agonist. It activates these receptors. And this causes four main things to happen in the heart. This is where some med speak comes in, but the source explains it well.
Lay it on me.
First, it increases heart rate. This is called positive chronotropy. Chronos, like time. Trope, like turning up the speed.
Okay, positive chronotrope speeds it up. Like digoxin would be a negative chronotrope, slowing it down.
Exactly right. Second effect. Increased strength contraction. The heart beats harder. That's positive inotropy. I know it refers to muscle fibers, so turning up the power.
Got it. And some heart meds are negative inotropes, making it beat less forcefully.
Correct. Third, it increases the speed of electrical conduction through the heart, especially through the AV node, that junction box. This is positive dromotropy. Dromo means like a path or a racetrack, speeding up the signal.
And the source mentioned adenosine as a negative dromotrope, the drug that slams the brakes on the AV node.
That's the one. Used to stop certain dangerously fast heart rhythms. So adrenaline does the opposite. Speeds conduction up, rate, strength, conduction, speed all increase.
Okay, sounds good so far. What's the fourth effect on the heart?
The fourth one. This is the downside. Adrenaline increases electrical irritability in the heart muscle.
Irritability, meaning it's more likely to misfire, have extra beats or dangerous rhythms.
Exactly. It increases the risk of things like PVCs, even dangerous rhythms like ventricular tachycardia, especially if the heart muscle is already weak or damaged. This is a significant potential negative, a limitation you have to weigh up.
Okay, so beta-1 in the heart, faster rate, chronotropy, stronger beat, inotropy, faster conduction, dromotropy, but also more irritable. Got it. 2 down. Alpha-1, beta-1. What's effect 3?
Effect 3 involves beta-2 receptors.
Beta-2, where are those?
Lungs, primarily in the airways, the bronchi and bronchioles. So the mnemonic holds: 1 heart, beta-1, 2 lungs, beta-2.
Nice. Okay. And adrenaline is a beta-2 agonist too.
A powerful one, yes. Activating beta-2 receptors causes bronchodilation.
The airways open up.
Exactly. They relax and widen. This is obviously crucial when someone's airways are dangerously constricted, like in a severe asthma attack or anaphylaxis.
The source compares it to salbutamol, right?
Yeah,
Methylene or albuterol.
It does. Salbutamol is also a beta-2 agonist, very common, used by patients and paramedics. But the source kind of frames salbutamol as a gentle nudge. It mostly hits beta-2. Adrenaline, though, is described as a powerful kick.
Hits beta-2 hard, plus it has those alpha-1 and beta-1 effects too.
Right. So when things are really bad, life-threatening airway closure, adrenaline is the drug you reach for.
And for this, paramedics usually give it IM, intramuscularly. Dose around, 200 to 500 microgram?
That's typical, yes. But here's another interesting point the source raises. Almost a bit of a contradiction in practice.
Oh, what's that?
Using adrenaline just for severe asthma when it's clearly not anaphylaxis is technically off-label.
Off-label, meaning the drug manufacturer doesn't list asthma as an official indication.
Correct. And major international guidelines, like from NECA or GINA for asthma management, they don't routinely recommend adrenaline for asthma alone.
Paramedics do use it for severe asthma sometimes, right? It's in protocols.
It often is, yes. So you've got this discrepancy. Field protocols in some places include it, but the formal guidelines and licensing lean away from it unless there's anaphylaxis involved.
How does the source explain that? Is it just outdated protocols?
The source doesn't explicitly say outdated, but suggests it reflects how field practice sometimes evolves based on, perceived effectiveness in critical situations and the available evidence. Maybe sometimes getting ahead of the formal guideline review process. It definitely flags it as an area needing more research. Is it truly effective and safe for just asthma? Or should we stick to other treatments? It's a point of critical evaluation, a limitation or uncertainty in its application.
Okay, fascinating. So alpha-1, vessels, beta-1, heart, beta-2, lungs causing bronchodilation, but with that off-label question for asthma. What's the fourth and final major effect?
The fourth effect is all about stabilizing certain immune cells, mast cells and basophils.
Okay, what do they do?
Mast cells live in your tissues, basophils circulate in your blood. Both are packed with little granules full of basically inflammatory chemicals, mediators.
And this is where the source uses that Venice under invasion metaphor.
Yeah, it's a really helpful way to picture inflammation. Imagine your body is Venice. Bloodstream is the canals. White blood cells are the warships. Body cells are the buildings.
Okay.
Now imagine you have defensive mines planted in the tissues and canals, those are the mast cells and basophils, When an invader shows up, like bacteria or an allergen, these mines get triggered.
And they explode.
They release their cargo, all those inflammatory chemicals flood the area. These chemicals do things like open up the canals, vasodilation, and make the canal walls leaky.
So the warship white blood cells can get out of the bloodstream and into the tissues to fight the invader.
Exactly. It's a normal, helpful defense mechanism, usually localized. But in anaphylaxis, the source says the system goes haywire, dangerously trigger-happy.
So instead of a few mines going off where needed,
millions of them explode all over the body systemically. Just a massive, uncontrolled release of these inflammatory mediators everywhere.
that sounds bad, like your own defense is turning on you.
It is bad. It's that out-of-control chemical warfare. You get widespread vasodilation, so blood pressure plummets. Vessels leak fluid everywhere, causing hives, swelling, and those mediators also cause airway constriction. It's life-threatening shock.
Right. So we know adrenaline helps by opening the airways, beta-2, and supporting blood pressure, alpha-1, beta-1. How does this fourth effect help with the mast cells?
This is the crucial part for anaphylaxis. Adrenaline directly stabilizes the membranes of these mast cells and basophils.
Stabilizes them, like makes them tougher, harder to burst open.
Precisely. It makes it harder for them to degranulate, to release all those excessive inflammatory chemicals that are causing the whole cascade.
Wow. So it's not just treating the symptoms, it's actually trying to stop the underlying chemical release at the source.
Exactly. And that is why the source calls adrenaline the perfect drug for anaphylaxis. It hits every major problem, constricts the dilated leaky vessels, alpha-1, speeds up the failing heart and strengthens its beat to raise BP, beta-1, dilates the constricted airways, beta-2, and it helps shut down the root cause by stabilizing those mast cells and basophils.
It's like the ultimate multi-tool for that specific emergency.
Pretty much, which explains why those auto-injectors, the EpiPens, are designed to deliver a solid dose, usually around 500 micrograms, right into the muscle.
Yet the comprehensive action really highlights its strength in that context.
Definitely. It's a prime example of why it's considered so fundamental.
Okay, so let's recap those four big effects. Alpha-1 vasoconstriction, beta-1 heart stimulation, beta-2 bronchodilation, and mast cell stabilization. How do paramedics put all this together in practice?
Well, we've covered the main scenarios, right? Cardiac arrest, primarily using alpha-1 to help CPR perfusion, but keeping that paramedic 2 debate firmly in mind.
Right, the uncertainty there.
Anaphylaxis, the perfect storm drug hitting all four mechanisms, given IM. Severe asthma or bronchospasm relying on beta-2 given IM, but remembering that off-label guideline discrepancy we talked about.
Got it. And the source mentioned two more key uses. Symptomatic bradycardia.
Yeah, when the heart rate is dangerously slow, causing symptoms like low blood pressure or dizziness. Here, paramedics are directly using those beta-1 effects, the positive chronotropy, inotropy, gerombortropy, to basically give the heart a biological jumpstart, speed it up, make it beat stronger, conduct faster.
And this is often used after trying other things first, like atropine or pacing.
Often, yes. It's usually given as an IV infusion, carefully titrated. You adjust the drip rate based on how the patient responds.
Which leads into the fifth big use the source mentioned, normovolemic hypotension, especially in vasodilatory shock like sepsis.
Right. Normovolemic just means the patient isn't necessarily dehydrated or bleeding. They have enough blood volume, but their blood pressure is dangerously low because their blood vessels are massively dilated, wide open.
Like in sepsis, where the infection triggers all that inflammation.
Exactly. The inflammation causes a systemic vasodilation. The heart might be pumping okay, the tank might be full, but there's no pressure because the pipes are too wide. In this case, adrenaline is used systemically, again, usually by IV infusion, acting as a vasopressor.
Using mainly its alpha-1 effect to squeeze those vessels body-wide and bring the pressure back up.
Precisely.
Right.
But, and the source really hammers this home, there's a critical prerequisite.
You absolutely must make sure the patient actually has enough blood volume and that their heart is functioning reasonably well first.
Yes. You can't effectively squeeze empty pipes or pipes connected to a failing pump. Trying to use a vasopressor without addressing volume or pump issues first can be useless, even harmful. It often means giving IV fluids before or while starting the adrenaline infusion. It's a key part of the assessment and safe application.
Makes sense. Now, administration routes. We mentioned IM for anaphylaxis asthma, usually the upper outer thigh.
Yep. Anterolateral thigh, vastus lateralis muscle, middle third is the sweet spot. The source notes you can go through clothes if you absolutely have to in an emergency, but direct skin contact is better. And it gives some practical tips For patients who are obese, sometimes you aim lower on the thigh or even use the calf muscle if it's easier to reach muscle tissue there.
And that point about repeat doses IM, if you need a second EpiPen.
Use the other leg. Definitely. You don't want to concentrate too much adrenaline in one spot because that intense local alpha-1 vasoconstriction could theoretically damage the tissue, spread the load.
Okay. And the old way, down the breathing tube at a tracheal, less common now.
Much less common, yeah. The main alternative to IM is IV or IO interosseous, directly into the bone marrow cavity, which acts like a non-collapsible vein.
And these require more training.
Absolutely. IV-AO is the preferred route for cardiac arrest, for those bradycardia infusions, for the vasopressor infusions in shock. You aim for the biggest, most central vein you can access safely, usually in the arm. The source cautions against using leg veins in elderly patients or those with known vascular disease because circulation might be poor down there.
And before you push any drug UVA, especially adrenaline, the source highlights one absolutely critical step.
Confirm. You are in goofy vein. Check, double check, triple check.
Why is that so critical with adrenaline?
Because of the danger of interstitial injection or extravasation. If that IV catheter isn't perfectly in the vein and you inject adrenaline into the surrounding tissue instead,
the local alpha-1 effect clamps down hard.
Extremely hard. It can completely shut off blood flow to that patch of tissue and cause necrosis, tissue death. It's a serious complication.
So what do you do if that happens, if you realize it's gone interstitial?
The source lays out clear steps for field management. First, stop injecting immediately. Try to aspirate. Pull back on the syringe, see if you can get any adrenaline back out. Then, discontinue the IV line, take the catheter out, elevate the limb to help with drainage, and apply a warm pack heat encourages vasodilation, which might help counteract the adrenaline and wash it away faster.
And you have to let the receiving hospital know ASAP.
Absolutely, because they have the antidote, essentially. A drug called phentolamine. It's an alpha-1 antagonist. It directly blocks adrenaline's vasoconstrictive effect. Paramedics generally don't carry phentolamine. So managing that risk of extravasation, knowing what to do if it happens, that's a critical safety point, a real-world limitation of IV use you have to respect.
The source also mentioned something about manually doing IV infusions in the field without a pump. For bradycardia or vasopression.
Yeah, it describes a kind of workaround method. You take 1 milligram of adrenaline, which might be in an ampoule confusingly labeled 1.100 or maybe diluted to 1.10,000, but it's still 1 milligram of drug, and mix it into a big bag of saline, like a 1-liter bag.
Giving you a concentration of 1 microgram per milliliter.
Right. Then you run it wide open for a moment to start, but then immediately slow the drip rate down using the roller clamp on the tubing, counting the drops. Maybe aiming for 2 drops per second, then 1 drop per second, adjusting based on how the patient's blood pressure or heart rate responds.
The source acknowledges that doctors and nurses would probably shudder at how imprecise that is compared to an electronic pump.
It does. It's a clear methodological limitation of doing this in the field without the ideal equipment. It's a necessary improvisation sometimes, but it highlights the challenge of delivering that kind of titrated therapy accurately pre-hospital.
Okay. We've covered a lot. Mechanisms, uses, how it's given, the risks like extravasation. What about who shouldn't get it or need special caution?
Well, the source makes a really strong statement about absolute contraindications, reasons you just never give a drug.
Right.
For those listed life-threatening emergencies, we talked about cardiac arrest, anaphylaxis, truly severe asthma airway closure.
Yep.
The source basically says there are no absolute contraindications. If the patient needs it to survive right now, the immediate threat outweighs pretty much any other concern. You give the drug.
That's a powerful stance.
Yeah.
But surely there are adverse effects and situations outside immediate death where you need to be cautious.
Oh, absolutely. The adverse effects make sense given what it does, right? It stimulates the sympathetic nervous system. So you expect palpitations, feeling anxious, maybe shaky tremors, headache, definitely a fast heart rate, tachycardia. And we mentioned the risk of abnormal heart rhythms, arrhythmias. Plus, it makes the heart work harder, so it increases myocardial oxygen demand, which could be bad if someone already has underlying heart disease.
Okay. And who are the specific patients where you need to be extra careful if it's not immediately life or death?
Right, the precautions. The source lists several. Patients who are already dangerously hypertensive, really high blood pressure, like in some strokes or certain pregnancy complications, because adrenaline will push it even higher.
Makes sense.
Patients with thyrotoxicosis, an overactive thyroid gland, because they're already sort of physiologically revved up with sympathetic stimulation. Adding adrenaline on top is risky. Diabetic patients' adrenaline can raise blood sugar levels, causing hyperglycemia. People with narrow-angle glaucoma.
And that weird one, pheochromocytoma.
Yeah, those tumors on the adrenal glands that are full of adrenaline themselves. Giving outside adrenaline can apparently trigger these tumors to release their own massive stores. Very dangerous situation.
Wow. Any others?
Parkinson's disease patients might get temporarily more agitated or have worsening tremors, and the source re-emphasizes that specific risk with rapid 5E administration, high risk of causing a stroke, a cerebrovascular hemorrhage, or triggering those dangerous cardiac dysrhythmias. So lots of cautions, but again, the source's main point holds. In a true listed life-threatening emergency, the benefit of giving it outweighs these potential risks.
What about interactions? Does it clash with other common medications?
It definitely can. The source highlights a few key ones. Beta blockers drugs many people take for high blood pressure or heart conditions. They do exactly what their name says. Block beta receptors.
So they could block adrenaline's beta-1 effects on the heart or beta-2 in the lungs, make it less effective?
Exactly. Less effective for bronchodilation, less effective at speeding up the heart if that's what you need. And specifically, non-cardioselective beta blockers, ones that block both beta-1 and beta-2, can be tricky. If you give adrenaline, the beta effects are blocked, but the alpha-1 vasoconstriction isn't.
So you could get unopposed vasoconstriction, leading to really high blood pressure.
Potentially, yes, it's a known interaction.
What about recreational drugs?
Cocaine and cannabinoids are mentioned. They can increase the overall sympathomimetic effects, basically, add to adrenaline's stimulant effects, could lead to an exaggerated or even toxic response.
And there was one group of prescription drugs mentioned as a major caution, MAOIs.
Yes, monoamine oxidase inhibitors. This is a really critical interaction the source flags. MAOIs are antidepressants, but they work by blocking an enzyme, monoamine oxidase.
And that enzyme normally breaks down adrenaline.
That's right. It's one of the main ways the body gets rid of adrenaline. So if someone is taking an MAOI, their body can't clear adrenaline efficiently. If you then give them a standard dose of adrenaline,
It just builds up like an effective overdose.
exactly, it can lead to a hypertensive crisis or other severe toxic effects. The source really stresses this as a major caution. Paramedics need to be aware of asking about MAOI use is important if the situation allows.
Wow. Okay.
Oh, yeah.
We have really covered a lot of ground here.
Yeah.
From, that ancient instinct in sheep clans by 1800
Through patent wars, the name confusion.
to the detailed cell receptor mechanisms, the life-saving uses, the controversies like Paramedic 2.
The critical risks like extravasation, the interactions.
It really shows how understanding this one chemical is just fundamental to emergency medicine.
It really is. It's a drug that kind of embodies the whole story of medical progress, doesn't it? Its power comes from tapping into our body's own deepest systems, the fight or flight. But using it well means understanding all those nuances, the different receptors, the history, the limitations that new research like Paramedic 2 reveals, knowing the administration techniques inside out, being vigilant about interactions.
And for you listening, whether you work in healthcare or you're just fascinated by how your body works, digging into adrenaline like this, well, it's not just about learning a drug name. It gives you real insight into your own stress responses, into pharmacology, into how medicine targets specific pathways. You've just done a proper deep dive into something truly fundamental.
Absolutely. And the source, interestingly, it kind of leaves us hanging with some really thought-provoking questions. It highlights that even with a drug this old, this basic, the story isn't over. There's still stuff to figure out, still debates ongoing.
Yeah, like thinking about that Paramedic 2 trial again. How should we use adrenaline in cardiac arrest going forward? How do we weigh that initial survival boost against the potential downside for long-term good neurological recovery? That's a huge ethical and clinical question.
And what about the asthma issue? Given that gap between some paramedic protocols and the international guidelines, what specific research do we need to really nail down adrenaline's proper role, if any, in severe asthma without clear anaphylaxis?
And thinking about the practical side, delivering those IV infusions safely in the field without pumps. That manual titration method sounds tricky. Could there be better protocols or maybe new, simpler technology to help make that safer and more precise in an ambulance or at an emergency scene?
That historical patent fight over adrenaline set a precedent. What are the ripple effects today? What are the implications, good or bad, of being able to patent naturally occurring molecules for things like research access, drug development costs, and ultimately patient access to medicines?
And we talked about adrenaline versus noradrenaline. They're similar but different. Could understanding those subtle differences even better lead to more tailored treatments, maybe using one versus the other more specifically, depending on the exact type of shock or emergency.
And finally, those drug interactions, especially with things like MAOIs or beta blockers. How do we make sure paramedics, nurses, doctors, everyone involved in emergency care have the best possible training and maybe quick reference tools to catch and manage those interactions safely when things are happening fast?
These aren't simple questions with easy answers, but they all flow directly out of the complexities and the history discussed in the source material. It really shows that even the most fundamental aspects of medicine are constantly evolving.
Exactly. The deep dive continues. In a way, it always leads to more questions.
Well, thank you for joining us for this deep dive into adrenaline. Keep exploring, keep learning.